Thanks. How AI can help us improving all the problems you were mentioning this morning in all the levels. This is a more, let's say, less, I don't know the word. Anyway, a different lecture. Anyway. The explosion is happening, and we are seeing and we are talking every day about this technology. And my disclosures here is that to create this talk, I used ChatGPT, but the way it should be used is that you use it to gather information and to make you aware of what's happening, but at the end, you are responsible of all the decision, of everything you show. So you are the ultimate responsible and not the AI. And this is to create a presentation, but also in daily practice, in medical practice. 1960, this is 40 and 25, 60 years ago, right? This is how somebody thought medicine would be in the future. You would be hooked to machines and they will do the diagnosis that will be confirmed by clinicians. So somehow I think they were right. And at the end, you will get a treatment or a diagnosis, but checked and supervised by real doctors. The explosion is happening in the last 8, 6, 5, 7 years, either for medicine, but also when we are looking into stroke. And like everything in life, we are probably experiencing this hype cycle where we can guess where we are, but probably we're here, and this is going to continue to grow very fast in the next months and years, and at the end it will stabilize somewhere. But I'm sure we are still on the growing zone very fast. Now, some data that help us understand why we need this kind of technology. So we are increasing by 10-12% the number of CT, MR scanning, and we can only increase by 3% the people that can read these images. And the number of patients that are waiting more than a month for reading the results is huge and continues to grow. So we're not able to keep with the pace what we are generating images to analyze them. In 2010, it took 3.5 years to double the amount of medical data, and 10 years later, it took only a couple of months. So we are generating and creating data that we are not able to analyze as good. The average radiologist interprets an image every 3-4 seconds when he's working. So you cannot reduce this much more. And if you try to reduce this, you're going to increase your rate of mistakes and errors. And this is a problem, especially for the patients, but also economical problem resulting. So we're getting to the limit where we can, without the help of additional technology, interpret at least radiological exams. And this is why the number of AI-powered medical devices has spiked in the last decade. And here you can see, this is the number of approved, FDA-approved devices that continues to grow after 2023, of course. And the easiest or the most appealing would be in the radiology field, where you deal with images. It looks the low-hanging fruit, let's say, and this is why there is this unbalance. And most of the devices approved are related with radiology, and here you can recognize many of the companies we are working as neurointerventionalists or neurologists in stroke care. So those are the top companies that have some kind of devices approved. However, the first device, AI-powered approved, was in 1995. Nothing to do, not related. It was for histology, but after that, most of them were related to radiology. And what we can do with AI, I have this list here that I'm not going to read, but basically you can better interpret and analyze signals from many sources, right? And if you apply this for stroke, you can apply this in every step of the stroke chain, from the initial diagnostic, even prevention, primary or secondary prevention, but up to treatment, acute treatment, endovascular treatment. We're going to see some examples. Again, this is not meant to replace professionals, just complementary technology, and I'm going to enhance and repeat this several times. But if we have the classical workflow of a stroke patient, AI can be applied anywhere, as I said, and it has to be somehow something seamless that in order that we are going to adopt it and think about the solutions that we are adopting today, they should somehow make our life easier and our work easier and lighter, and not the other way around. So if this is not the case, they are not going to be successful, and we're not going to adopt it. So if you are involved in developing this, the first thing is that it should be useful, but also making our work easier. Okay, and so for decision support, for the safety, enhance the safety, for increase the privacy, cost effectiveness, for any of these items that I'm listing here. And for example, already at the pre-hospital setting, we can use some devices that can interpret signals, right? And these kind of signals with AI interpretation, they can lead to better results and prediction. And the beauty of this is that you can combine, and I'm going to show you later other examples, what you get from the machines and the sensor with different sources, with physical exam, with baseline characteristics of a patient. You can combine in these algorithms different sources of information, and you improve your accuracy. Another very promising tools are face, speech, movement identification from videos that the patient's family can take, and these are examples in the hospital, but imagine you can take them even before EMS gets to the scene. You can ask a witness to take a short video, and we're working on this, and you can grade and quantify facial asymmetry very fast. You can grade and quantify also the drift, or the difference in the drift and the strength. So it can be used in the acute phase, but also in the follow-up to grade better than we do now, better than the NIH or the MRS. You can grade in an independent way how the patient is improving, or at the beginning. So by mixing, for example, drifting velocity and the maximum height, you create these variables, and you can compare both sides, and you can calculate, measure in a very elegant way what is the degree of impairment, in the motor impairment. And these tools, they claim that they can predict if this patient is having a stroke mimic, or even if the patient is having a large vessel occlusion stroke as compared to a non-large vessel occlusion stroke, because there are cortical signs or others. So very promising. There are several projects that are exploring this, and we're going to see them for sure. Next, blood biomarkers, point of care. Instead of measuring one single molecule, you can measure several, and the combination of them, if you measure this with these algorithms, you can again predict if this is going to be a hemorrhage, a large vessel occlusion, or what is the already in the ambulance before getting to the hospital. And other sources like neurophysiological reads that can predict what is going to happen in the brain, like the helmets that Paul was mentioning before. Other examples are these. This is a very beautiful solution that is aimed to detect unwitnessed strokes, people with high probability of suffering a stroke that live alone. They can wear these bracelets, and they measure all the time the movement. And if they identify that there is an asymmetry that looks like the patient there's a pattern that suggests a stroke, they create a first alarm level, and then if the patient does not respond, they escalate the alarm. And it's also very, very, very promising, very easy, very comfortable to wear. In terms of transferring solutions, we did this trial by which we were randomizing patients that were living far away from a comprehensive stroke center to go to the closest or bypass the closest center and go to the comprehensive. We didn't find differences in rate of good outcomes overall. Those were patients that were screened with a pre-hospital scale by EMS, and again, we didn't find that one solution is better than the other. So the best is we decided to transfer to the closest and optimize in-hospital circuits. However, we created what we call digital twins. So you create a digital twin that was receiving the other solution, and the algorithm predicts the outcome if that single patient had received the other transfer option. And then you train this algorithm to identify the differences. So the algorithm identified that in 376 patients, yes, they could predict that it was better to go to the thrombectomy center. So now, if we look at what happened in reality with these patients, so yes, we found that those patients were really transferred to a thrombectomy centers, they had 10% higher chances of good outcome. So one algorithm like this could increase by 10% the chances of good outcome by suggesting the better option for transfer and the bypass. So we can help ourselves with this kind of technology to make these decisions rather than only on pre-hospital scales, because it integrates time of the day, distances, ages, historic characteristics of baseline characteristics of the patients, past medical history, all these you can integrate. Also, you can start creating sensors. Those are very rudimentary pulse sensors that you place on the carotid, but they monitor all the time the pulse in both carotids. And if a large vessel occlusion happens during a surgery or while the patient is sleeping and nobody notices the symptoms, they generate an alarm, so you can monitor by pressure. And if this works, you can miniaturize this kind of pressure sensors, and you can even create implants that you will put subcutaneously, for example, and they will be monitoring all the time what is happening. So very promising technology also. In the hospital, of course, we are already working with AI to make easier the life of the X-ray technicians. They can help isocentering, collimating, so making it routine activities. They just do them automatically, eliminating artifacts from images, of course. This we can already achieve today. So as of today, cone-beam CT is a clear example. There are ways to reduce artifacts of cone-beam CTs, and we got to the point that sometimes it's difficult to differentiate the quality of the image that was acquired on a conventional CT or on a cone-beam CT, because the one on the left is enhanced by AI. So yes, there's still a difference, but the quality of the cone-beam CT is enough to make all decisions related to IVTPA and to thrombectomy, and because of that, we can take patients directly to the angio suite. We have enough imaging quality. Thanks to the AI, it can reduce the dose, right? The radiation dose, you can reduce it with AI, as you can see here. And of course, this we all know because we are stroke doctors, and we have been working with these kind of tools that on real time gives us the prediction of large vessel occlusion. And again, remember, the FDA had to launch this advice that we should never replace our interpretation as physicians. We can just use this to prioritize the exam, to focus our work, to check rapidly, immediately what happens with these patients, but we should always verify the interpretation of the AI. And we are already able to identify large vessel occlusions without contrast, so AI is complementing and we can use AI instead of contrast to detect large vessel occlusion, also to detect the core. And again, the nice thing is that you can combine medical data like the NIH with the imaging, and you can improve even more your accuracy. Here you can see very well what is going to be only with the non-contrast CT. So no need to perform CTA or CTP already from the non-contrast CT. And imagine many hospitals around the world are not capable of performing contrasted imaging. So you can predict what is going to be the core, similar to what is going to be your CTP maps, and it matches what is going to be the final infarct. Many times, here's another example, already only with the non-contrast CT, you don't need to perform CTA or CTP, you already have all your information, and it will correlate very nice with the final infarct volume. From the CTA, we can get more than what we get. You can have these algorithms that will, in a few seconds, they will segment nicely and sharply all the vessels, and you can have the center line, you can measure the angles, the diameters, the distances, the lengths, and all this information, you take it, you construct, you segment the vessels, and instead of evaluating CTAs like you are used to, in very few seconds, you can check here the arch, where is the occlusion in the M1, as you can see here. It's going to be probably much easier and faster than on a CTA following these white dots that many times are a little difficult to identify. And from that, the next stage is ask an algorithm to identify or map, like a GPS, what is the best route to get to the occlusion. And we recently found that a deep learning algorithm can help you identify those patients in which the access from transfemoral access is going to be difficult. This is 5, 4, 6% of the patients. It is difficult, sometimes impossible, and you keep trying from transfemoral, and after 20, 30 minutes you decide it's going to be impossible. If your algorithm tells you that this is impossible, and now this is we have it in our institution. We receive for every single patient an email with this prediction. In this patient, going to the left carotid, to the left side, is going to be quite difficult. But sometimes I took these examples, but sometimes they tell us it's 0%, it's going to be impossible, and it really works. And here, if you want to verify, here this patient, he has a pretty sharp angle arising from the well, anyway, you saw that from the aorta on the left side, and this is going to make it quite difficult, not impossible according to the algorithm, but maybe in this case you may decide that it's going to be easier if you go radial, right? And then the next thing you can do is segment clots intracranially. So the algorithm segments where he thinks the clots, the volume where he thinks the clot is. And here you can see that the coincidence with the manual segmentation is very good. Sometimes overestimates, underestimates, but it's pretty good many times. And then you can take this volume and analyze radiomics here, and also combine with past medical history. This is the patient, a diabetic, atrial fibrillation, and you can predict predict what is going to happen in terms of recanalization, or which is going to be the device that you need to use. And now we are trying to train an algorithm that will predict if the patient will have an unsuccessful recanalization, or if this is going to be ICAD and you're going to need angioplasty and stenting. And we can see differences, or here the algorithm shows us where it looks the areas of interest for the algorithms, and you can combine with some variables. And here you can see that atrial fibrillation is the most powerful baseline variables that is associated with ICAD or non-ICAD, and you combine all these or the variables you think that make sense in an algorithm, and you can get pretty good prediction power about what is going to be what kind of tools you're going to need to recanalize this patient. And of course, we all can think that technology can help us grade the Tiki score. The Tiki score is quite subjective today, and many times we are not going to agree. If we generate a tool that will auto-grade Tiki, this is going to be great, especially for research. And another tool that can point us on the angiogram on real time if there are distal occlusions, and maybe we can grade the retrograde flow or collaterals, because this I use as an information. When I have a secondary MIVO, I use as an information if there is good retrograde feeling or not, to decide if I'm going to go after this or not. I'm finishing here, but the technology can detect the wires, the different catheters, and you can help in automatizing navigation. And by repetition of many times, the robots will learn better how to get. And here, this is a simple example, but here you tell the robot where he should go, and he will navigate autonomously and safely to the distal branch here. This is going to help us in navigating our robotic systems when we will use them more and more. And in terms of follow-ups also, you can generate these platforms that make interactions with the patients, their families. You can remind them about treatment, compliance with treatment, but you can collect what we call PROMs, patient-reported outcomes. How do they feel? What are the complications? And with this information, you can generate algorithms that will predict events. You can predict already from the first week or 2 weeks if this patient is at a high risk of having a recurrence or not, and in those who are not compliant. And you can combine with past medical history again. You can generate the probability of recurrence for each individual. You can even make him aware of that if he's going to control his risk factors, his rate of recurrence is going to be lower, or if he doesn't control and he doesn't take his medication, it's going to be higher. And you can point to him on real time, day after day, if he's in the low side of the high side of probability of recurrence. So this gives him a feedback about how good he is performing. You are empowering the patient, right? And you can insist with these algorithms on compliance, on sending reminders, on helping to control his vascular risk factors. You can either chat with a chatbot or with a person with him and encourage him to be more compliant or do more exercise. You can educate him according to his needs. And finally, we end with hallucinations. Hallucination is when this technology fails. We all seen hallucinations. I'm going to give you a couple of examples, but this is why we need to supervise here. The same picture. This is a AI to predict melanoma. Just because there are more light on one of the pictures, the same lesion looks to the algorithm like a melanoma or not. So of course, this needs to be supervised, or just because you rotate the image that you feed the algorithm, it changes completely the prediction. So these algorithms, they fail, but they make you feel that you are better than the machine, right? Many times you see that there's the algorithm raise the hand and tells you there's an LVO here, but then you check the image and you clearly see that this is just because of an anatomical variant, and then you feel wiser than the machine, and that makes you feel good, right? And it's not that the algorithm doesn't work or it's bad. It just helped you to focus your attention for a few seconds here. You're not gonna trust blindly the algorithm. You're just gonna see here it's a little mistake. Next time probably it will be right. So no, it's not a big issue. And here I want to raise the problem. These algorithms were designed with patients with high probability of having a stroke. Many times we run these algorithms to all comers, right? Everybody that comes to the ER receives a CT, CTA, CTP. And this is not the population for which the algorithm was validated. It's the accuracy of any diagnostic test will depend on the prevalence of the disease, right? If you test whatever in a very, very low prevalence, the results are going to be much worse than if you test something in a population where the prevalence is very high. So you should interpret the results of this according to what you feed. So you should know at least what is the NIH of this patient and what are his symptoms. If you just had a TIA and you still did a CTA, of course, the patient does not have any symptom, but yeah, possibly many times the algorithm will detect some kind of anomaly or an LVO, but this is crucial. So many times we end up with this kind of publications where they say AI is bullshit, in the sense that maybe they are right, the models are indifferent to the truth of their outputs. So they don't care if they are right or wrong. They just say whatever they analyze in this moment. But they don't have an insight about what happens if they are wrong or right. So make at least this, also remember this. And I think, yes, I'm done, but with this kind of technologies, you can get these tools that are amazing, that certainly can help us in everyday practice, and that's it. Thank you very much.